For my research topic, I decided to look into antidepressants and how they have and are being used to treat children with depression. After reading through my anchor source, I realized that over the past decade, there has been a huge controversy with this topic. My anchor source then helped me develop my research question, which is, are antidepressants doing more harm than good for children with depression? So to start off, I want to go over what antidepressants are for those of you who don't know or just need a better understanding. Antidepressants are a class of drugs that reduce symptoms of depressive disorders by correcting chemical imbalances of neurotransmitters in the brain. And now for depression, which I am sure most of you are familiar with, but I am still going to give a brief definition. Depression is a mental health disorder characterized by persistently depressed moods or loss of interest in activities, causing significant impairment in daily life. Moving on to the next slide. Over the past decade, there has been a controversy regarding children and adolescents with depression and whether or not antidepressants should be a treatment option for them. The people against antidepressants believe that they cause suicidal behavior after trials were conducted in 2004 said so. They also agree with black box warnings on antidepressants applied by the FDA. Those who are pro-antidepressants don't believe that the studies were accurate or conducted properly and believe that the black box warning on antidepressants have become an issue. And now for my anchor source. I chose this article because the author Yesong Du is an expert in this topic and has supporting evidence for both sides of the controversy. Du states that depression can seriously impact a child's academic achievement, social interactions, and other aspects of their daily lives. I also added a statistic Du used to summarize the percentage of children and adolescents who have or will have depression. He then goes into the treatments for childhood depression. He states that cognitive behavioral therapy and interpersonal therapy are considered two of the most effective treatments for depression, but treatment with antidepressants is the most common method for treating childhood and adolescent depression. And now moving on to the third bullet point, which states that fluoxetine is the only drug approved by the FDA because it's proven to be effective. Other drugs like fluoxamine, which is used for children over 8 years old, and sertraline, which is used for children over 6 years old, have not been formally approved by the FDA. And also the newest antidepressants like venlafaxine and duloxetine have not been adequately tested on children, but they are still considered when other antidepressants have not been effective. Du then uses the 2004 study as supporting evidence to conclude that paroxetine caused suicidal ideation, which was one of the reasons the FDA required black box warnings on SSRI antidepressants that warn of risk of suicide when it comes to children and adolescents. And then to support the other side of the controversy, he states that the black box warning caused a lot of children and adolescents with depression to go untreated. Thomas B. Newman also uses the 2004 meta-analysis to support his claim that antidepressants shouldn't be used to treat children and adolescents with depression. He states that on September 14, 2004, the FDA Joint Advisory Committee voted 15-8 for the black box warning on antidepressants. This decision wasn't taken lightly because they took the time to look at a number of presentations summarizing the evidence, which mainly concerned newer antidepressants. which are known as SSRI antidepressants. Most of this evidence came from trials conducted by drug manufacturers, and from these trials the FDA indicated that only 3 of 15 trials of antidepressants used in children with depression have found a statistically significant benefit. The FDA's meta-analysis also suggested the new antidepressants doubled the risk from 2.5 to 5% when it comes to suicidal behavior or thinking. But also the committee members agreed that there are wide gaps in our knowledge about antidepressants. Richard A. Friedman tries to discredit the 2004 trials that were used to place black box warnings on antidepressants. He attacks the trials by stating that the trials were not designed to prospectively assess suicidal behavior or thinking. And then to continue attacking the trials, he states that the rate of suicidal thinking or suicidal behavior was only 4% among patients assigned to receive an antidepressant in the 2004 trials analyzed by the FDA. He also adds that none of the suicide attempts in the trials were fatal. He then starts his next claim by stating that the FDA's decision was immediately controversial because many members of the medical community were worried that the warning would do more harm than good. 2 years after the FDA advisory was issued, there was a 14.5% reduction in antidepressants use among adolescents, young adults, and adults. This is why in 2007, an expanded black box warning was issued by the FDA that stated that depression itself was associated with an increased risk of suicide. And even though once again in 2008 we saw an increase in adolescents using antidepressants to treat their depression, utilization stayed below 2004 rates. Friedman believes that the black box warnings not only affected children and adolescents, it affected adults as well. Friedman also believes that the warning should be removed entirely. Even though I didn't make a slide to point out my opinion, I'm going to do that now by agreeing with Dew, the author of my anchor source, and the opinion of just about every author in my articles. I believe that every child or adolescent needs to assess both the benefits and the risks of antidepressants and psychological treatment, and each patient should be assessed regularly to decide whether or not to make alterations in their treatment plan.